Hello, everyone, and welcome to this session, Demystifying the Science and Clinical Application of Cleansers and with Antimicrobial Preservatives and differentiating between hypochlorous acid, hypochlorite, and PHMB. And this is supported by an educational grant from Ergo Medical America. I'm Greg Schultz. I'm Professor Emeritus, Director of the Institute for Wound Research at the University of Florida. And joining me are my wonderful colleagues, Dr. Paul Kim and Mary Ann Obst, who are fantastic clinicians who will try to interpret my basic science into clinical useful information for you. To maintain CME accreditation, these are the lists of the disclosures for Dr. Kim and Mary Ann Obst and me. But because this is a CME approved presentation, we will maintain the standard of using scientific and clinical based data to present our information. And in no way are we trying to recommend any product promotions. Briefly describing our learning objectives for today, I will start and I will give you the basic chemistry and microbiology and biology of these important wound cleansing agents. And I will focus on reviewing hypochlorous acid as an antimicrobial preservative in wound cleansers, to use the phrase that the FDA allows for these types of products. And basically, I'm going to show you the chemistry and explain how hypochlorous acid is a very effective antimicrobial agent as a preservative, and also show you its safety as an agent, comparing it with other species. And then my wonderful clinical colleagues will examine the role of these cleansers in specific applications. And one of the most important and recent ones is in understanding its use for negative pressure with installation, especially for infected wounds. So starting with the cytotoxicity versus effectiveness aspect, if we look at these four major types of chronic wounds, obviously, as you know, there are different comorbidities and etiologies that combine to create these chronic wounds. But when we look at them at a molecular and cellular level, they're actually a lot more similar than they are different from what you would see and think from these different appearances. Information from multiple laboratories as well as clinical studies indicate that this hypothesis of chronic wound pathophysiology really starts with the idea that in all those four types of wounds, there are repeated tissue injury, almost always with some ischemia. But critically important is the bacterial bioburden component. And that includes both the single planktonic bacteria as well as the bacteria in the biofilm phenotype. Now, these bacteria phenotypes stimulate chronic inflammation, and we can assess that by looking at the levels of pro-inflammatory cytokines such as TNF-alpha and IL-1, IL-6 in wound fluids. And those draw in new macrophages and neutrophils into the area of the wound, and they activate. And that results, as I'll show you, in the generation of reactive oxygen species, which are critical in terms of the neutrophils and macrophages engulfing and killing the bacteria they've engulfed, but also in producing and releasing proteases, such as the matrix metalloproteases, as well as elastase. Now, these reactive oxygen species and proteases do good things when they're at the right time, right place, and right amount. But unfortunately, when they're present at hundreds of times the concentrations we see in an acute healing wound, and they're present for weeks and months, they begin to have off-target effects. that are characterized by the degradation of growth factors and their receptors, decrease in functional extracellular matrix proteins, and that results in decreased cell proliferation and migration, which we see clinically as an acute wound that's converted into a chronic wound. So overall, our objective is to reverse this amplifying cascade that starts with the tissue damage, but also with the presence of the bacterial bioburden. And we're going to focus quite a bit on the critical role that we now appreciate that bacterial biofilms play. Well, bacterial biofilms are not unique for chronic wounds. In fact, this excellent review in 2007 by DePozzo and Patel listed 18 clinical pathologies that were associated with and in fact caused many of these chronic inflammatory conditions. Everything that our otolaryngology colleagues know, from chronic sinusitis to our orthopedic colleagues, the prosthetic joint infection, essentially every tube that goes through the body, whether it's a urinary stent or a catheter of some type, will actually eventually become colonized, and the bacteria will convert into a biofilm phenotype. Now, in 2007, you notice that chronic skin wounds weren't included in this extensive list of clinical pathologies. So it's relatively recently that the field has begun to appreciate the critical role that bacterial biofilms play in producing the chronic inflammation and impairment of healing that we see in chronic wounds. One of the critical questions first try to establish is how common, how frequently are bacteria in a biofilm phenotype identified in chronic wounds? And the recent review by Matt Malone and colleagues from Australia showed that in a meta-analysis of multiple studies that were performed on chronic skin wounds by different investigators, they could identify the presence of biofilm structures in approximately 80% of the biopsies that were taken from these chronic wounds. And in the middle panel B, you can see a scanning electron micrograph of a relatively typical bacterial biofilm mass, this community and this self-produced exopolymeric matrix that constitutes the tightly attached biofilm. Now, the biofilm, as I'll show you, is not present only on the surface of the wound, but as shown in panel A, it turns out that biofilms can actually also form beneath the surface of the wound, oftentimes down several hundred microns from the surface of the wound bed. And while both the bacteria as well as the exopolymeric polysaccharides that constitute a majority of the biofilm component, it turns out that another critical unique aspect of bacterial biofilms is the presence of a substantial amount of free extracellular bacterial DNA. So in panel E, you can see bacteria rods that are stained with a dye, and so they appear green. But in between those bacteria, you see red staining, and that's the dye that detects only extracellular DNA. And so you can see a substantial amount of the exopolymeric matrix that constitute biofilms is actually free extracellular bacterial DNA. And there are unique sequences called CpG islands that are present in only bacterial DNA. And we have evolved the ability in our innate immune system, our toll-like receptor 7, can actually recognize those unique sequences in bacterial DNA to mount a much, much faster immunological response to the formation of a biofilm. One of the key questions we want to ask about biofilm is, why are bacteria and biofilms so hard to kill? And the reality is there's multiple answers. First, the exopolymeric matrix of the biofilm can be a diffusion barrier for large molecules. In addition, the polysaccharides and bacterial DNA that make up a substantial amount of the exopolymeric matrix materials can actually chemically react with and therefore neutralize many of the chemically reactive microbicides that we normally would use. And many of the polysaccharides are actually negatively charged, as well as the bacterial DNA. And so these have a negative like cloud that is able to reduce the penetration of positively charged materials, like unfortunately many of our antibiotics or some of our cationic microbicides or cationic surfactants. A critical piece of information, though, is understanding that many of the bacteria, as I'll show you in mature biofilms, have very low metabolic activity. And these persister bacteria are highly tolerant to antibiotics because antibiotics only kill metabolically active bacteria by interfering with essential bacterial protein systems like protein synthesis, DNA synthesis, or transport proteins. Also, much of the metabolic activity that is present is found in the bacteria on the outer shells of the biofilm. And so oxygen gets consumed better in the outer layers of the biofilm, and this promotes the growth or creates a niche for strict anaerobic bacteria, as I'll show you in the center of the biofilm. Finally, almost all of these biofilms in chronic wounds are not one species. They're not monospecies. They're polymicrobial. And so there's a potential for synergism if there is a genetically resistant colony of bacteria like a MRSA adjacent to a non-genetically resistant bacteria, just a regular Staph aureus. And so they can provide bystander effects that can help the bacteria survive. And finally, bacteria like Pseudomonas actually secrete catalase, which helps to destroy one of the key reactive oxygen molecules, the hydrogen peroxide. Well, I showed you that biofilms can have significant tolerance to antibiotics, and these are the data that support that. So in the left panel, you see that when we grow typical rapidly metabolizing, proliferating planktonic Pseudomonas aeruginosa and expose them to high concentrations of tobramycin, you can see that after about 4 hours, all of the planktonic bacteria are killed. In contrast, if we grow those same sensitive bacteria in a mature biofilm and expose them continuously to that level of antibiotics for 4 days, it kills less than 1 log. Now, this isn't permanent genetic resistance, because if we ultrasonically disperse those tolerant biofilm bacteria back into planktonic bacteria, they start proliferating. Now they are susceptible to the antibiotic again, just like when we started with a planktonic culture. And as shown in the right panel, the reason why the biofilm bacteria can frequently develop this temporary tolerance is because typically only bacteria in the outer shell of a mature biofilm are highly metabolically active. And as I indicated, antibiotics only kill metabolically active bacteria effectively. So the outer shell is sensitive to the antibiotic, but the inner layer, inner shell, inner mass of the biofilm is highly tolerant to those antibiotics. It's also important for us to remember, especially as we talk about the hypochlorous acid, is that this is one of the major reactive oxygen species that our body makes, our neutrophils and macrophages make to actually kill bacteria that are contaminating and colonizing the wound. So when you see in the right and the left panel, this just shows how a neutrophil would encounter and be drawn to a bacterium. It engulfs it in a phagosome. It generates, as I'll show you in the middle slide, the respiratory burst. The pathogens get killed due to the action of the reactive oxygen species, especially the hypochlorous acid, and then eventually the neutrophil can just release the dead bacteria and components. So this respiratory burst is critical for us to understand, because what happens is as soon as a bacterium gets engulfed in the phagosome, there is an enzyme complex called NADPH that actually takes electrons from NADPH and adds it into molecular oxygen, generating this superoxygen radical, which then can be protonated to make hydrogen peroxide, H2O2. But even more importantly, within the phagosome, the azure granules will fuse and secrete the myeloperoxidase enzyme, and that will add a chlorine molecule onto the hydrogen peroxide and make the hypochlorous acid, which is the terminal reactive oxygen species that our neutrophils and macrophages make. Now, this happens extremely rapidly, as shown in the right-hand panel, where a neutrophil is engulfing a yeast cell, and within minutes, the false color staining indicates the amount of reactive oxygen species that's being generated in the endocytic vesicle that has phagocytized the bacterium. It's also critical for us to understand the chemical formulas, the chemical structures that exist for hypochlorous acid at different pH. And as you can see, the middle portion here, the pKa of hypochlorous acid is about 7.5, which means that at that pH, half of the hypochlorous acid has deprotonated and become the sodium hypochlorite anion. Now, hypochlorite has much lower oxidative potential than hypochlorous acid. So blah, blah, biochemically, what that means is the hypochlorous acid is much more effective at engulfing and killing bacteria than the deprotonated hypochlorite anion. Now, the optimal pH for this is from about 4 to 5, where essentially 100% of the hypochlorous acid molecule will be protonated. That's much different than in Dakin's solution, which has a pH usually of around 10, where there's essentially none of the hypochlorous acid molecule left because it's all been deprotonated. So really, optimally, what we want is the hypochlorous acid form of the molecule because of its higher oxidative potential and higher microbicidal potency. The relative microbicidal activity of hypochlorous acid compared to sodium hypochlorite is shown here, where you can see that the HOCl form of the molecule has much lower minimum bactericidal concentration. So that's what we want. We want something that's very potent and doesn't require a high concentration to kill the bacteria. We can compare the effects of hypochlorous acid to an antibiotic like mafenide. And these data just basically show that even with gram-positive, gram-negative, or yeast bacteria and microbiomes, you can see that the ability to kill these bacteria and yeast is highly improved using HOCl compared to the antibiotic of the mafenide. So this shows the ability of hypochlorous acid across all of the major types of bacterial species within wounds to be an effective microbicide. The previous slide was done on planktonic bacteria. Well, what about its effects on biofilm? These types of laboratory data show that even with a Pseudomonas biofilm grown in the lab in a tube reactor, can be very effectively killed within a matter of minutes by concentrations of the hypochlorous acid that are present, for example, in the pH stabilized wound cleansing solutions. While it's important to have a very excellent low microbicidal concentration, minimum microbicidal concentration, we don't want to kill all the bugs and also kill all the wound cells. So what is important is to have a balance between good microbicidal activity but low cytotoxicity. And using cells in culture, you again can see that the hypochlorous acid form is very low, has very low cytotoxicity, indicating a relatively high cell viability in this graph compared to other typical microbicidal agents. Emphasizing again the difference between hypochlorous acid and sodium hypochlorite, or cationic surfactant like PHMB, again, you can see that hypochlorous acid has significantly higher cell viability, even at different concentrations of these typical microbicidal preservatives. The previous data on cytotoxicity used cells in culture. Well, what about making it more relevant? So if we actually look at a typical experiment where the hypochlorous acid or the sodium hypochlorite is infused into the lungs of rats, you can see in panels A and B on the right that the hypochlorous acid is lung treated is extremely normal looking, whereas the lung treated with the sodium hypochlorite shows increased amounts of hemorrhage. And on a microscopic examination, you see the same type of results. That is, compared to normal saline in the top panels, you can see at both low and high magnification that the hypochlorous acid has minimal detrimental effects on the lung tissue compared to the tremendous hemorrhage and cell death that is occurring in the lung tissue lavaged by Dakin solution. Now, this combination of good microbicidal activity and good cell viability or low cytotoxicity is actually summarized in what's called a relative therapeutic index. So again, what we want here is a high number, something that has very good ability to kill the bacteria at low concentrations of the agent versus a very high cell survivability that is very low cytotoxicity. And again, you can see that the hypochlorous acid on this log scale is significantly better than either hydrogen peroxide or the hypochlorous anion. As you'll hear in the subsequent clinical presentations, one of the most important and emerging applications is to use negative pressure wound therapy with installation, and especially if a hypochlorous acid form is used as the installation fluid. And looking at the change in the bioburden using negative pressure therapy with installation compared to just negative pressure alone, again, you can see that the installation with a hypochlorous acid solution dramatically reduces the level of viable bacteria compared to just using negative pressure alone after 7 days of treatment. So to summarize very quickly, this information helps us to form a consensus recommendation on treatment of biofilms in chronic wounds. And this was summarized in what we call the step down, then step up treatment. In other words, basically, we want to start with aggressive debridement on a chronic wound when it presents, because there's almost always a biofilm present. But we need to combine that with effective treatments that can kill both residual planktonic and biofilm bacteria and prevent their reformation within a few days. So as the wound improves, the inflammation is reduced, the proteases and reactive oxygen decrease. Now the wound should begin to start healing on its own. But if the wound needs additional stimulation, then the wound bed is prepared well, and you can step up from standard care into using advanced therapies, and they will work very well because the wound bed has been prepared well. So in summary, you can read this, but basically what we need to appreciate is bacterial biofilms are a substantial impediment in most chronic wounds. We need to adjust our treatment strategies to remove the biofilm and to eliminate whatever is left. One of the most important molecules to do that is the hypochlorous acid. As I showed you, it's superior to the hypochlorite anion in both its low cytotoxicity as well as its very high microbicidal efficiency. And that this can be used in combination with other advanced treatments and therapies to rapidly reduce the bacterial bioburden in wounds, which is the core concept of step down, then step up biofilm-based wound care. care. So at this point, I'll turn over the presentations to my wonderful colleagues who will try to present this in a more clinically relevant format.
Hello, everyone. Thank you for joining this session at WoundCon. I appreciate your time. I want to thank Greg for his wonderful lecture that preceded mine, and also look forward to listening to Mary Ann's lecture. She's a very thoughtful and very engaging lecturer, and she has a wealth of experience as far as the use of this antiseptic Bosch solution. What I'm going to talk about today is the use of the antiseptic solution Bosch with installation therapy. My name is Paul Kim. I'm a professor in the Department of Plastic Surgery and Orthopedic Surgery at the University of Texas Southwestern. I'm also the medical director of the wound program here. Prior to my job here, I worked at Georgetown University Hospital for about 10 years, and we sort of pioneered some of the early work with the next generation of negative pressure wound therapy with installation. During that time, our thought process changed pretty radically. Initially, we used something called PHMB, polyhexanide with betaine. Polyhexanide is an antiseptic and betaine is a surfactant. I did a lot of literature search and reviewed the science and background on a variety of antiseptic solutions. I will tell you quite honestly, Bosch didn't really hit my radar at that point. So we landed on PHMB, and what we found was that the antiseptic was very potent. If you look across the literature, it's got some really good supportive basic science benchtop and animal studies supporting its ability to kill bacteria at a pretty high rate and a different species of bacteria. What we didn't know at that point was that there's some concerns regarding cytotoxicity using PHMB, as it's true with a lot of different antiseptics. And so our thought process changed. And when I came here 2 years ago, what I found was that Bosch solution was being used ubiquitously throughout our health system. And we have a 900-bed hospital in the inpatient side, and we have a very robust wound center on the outpatient side. And Bosch was being used for almost every patient as an antiseptic wash. So I started to look into the literature about Bosch solution and trying to examine its properties and seeing if that's a better irrigant, if you will, with installation therapy. If you don't know what negative pressure wound therapy with installation is, essentially you instill a solution on the surface of the wound. It dwells and soaks for a period of time. Then it's evacuated, and then negative pressure is applied. And there are some good studies, and we don't have enough time to go through it, including a recent meta-analysis that was published that really supported the use of the use of negative pressure wound therapy with installation. But I got asked over and over again, and I've given lots of lectures on this device about the antiseptic choice. What solution should they be using in their own institutions? And I thought I had the answer early on, but it turns out I may be wrong. And my thought has evolved to date, where I think Bosch solution is actually a very good choice. There's been a series of consensus panel statements that have been published over the last almost 10 years. I was able to lead many of these. And if you look across these expert consensus statements, early on, we really didn't have a lot of understanding, at least I didn't, and many of the panel members didn't, as far as selection of an antiseptic solution. And if you read through the years, you can see an evolution of thought as far as the use of antiseptic solutions. The most recent publication was published here just a couple of years ago. And it encompassed multiple different countries, including the United States, Canada, UK, Japan, and Germany. And this included nurses, podiatric surgeons, plastic surgeons, orthopedic surgeons, and general surgeons. We were asking more clinical questions at this point. There were 109 discrete questions that were submitted to all of the panelists. And we did what's called a modified Delphi method for consensus. Essentially, the questions are continually circulated until we come up with agreement that we will include in this paper. And then ultimately we came out with 11 consensus statements. If you look at the type of solution to be used with this device, Bosch solution actually came up pretty high. And this was the highest it's been across the consensus guidelines. And I think what people are learning with the use of antiseptics in general have really matured over the last 10 years, as well as the use of negative pressure wound therapy with installation. What really got me sort of scratching my head was this study. This was a prospective randomized multi-center study looking at standard negative pressure therapy versus that of installation therapy. In this case, we used something called PHMB. PHMB is polyhexanide with betaine. Polyhexanide is an antiseptic, betaine is a surfactant. This was a solution that I really studied in depth and trying to understand what the best solution is for this large, robust, multi-center study. And back then when the study was being designed, this is back in 2014, 2015, when I designed the study, it seemed like it was the ideal solution. Since then, PHMB, the data that's come out has emerged really, is that yes, it is a very potent antiseptic, but it also has some cytotoxic properties, which actually may inhibit wound healing at some point. And this is really reflected in the study that we published, because in this prospective multi-center study, one of the primary endpoints about clinical effectiveness was number of OR visits needed to have the wound ready for coverage or closure, meaning that final procedure. What time does it take? How long does it take for those things, that endpoint to happen where the wound is converted essentially to a healthy state? Well, the result of the study showed that it did not, installation therapy was not superior to standard negative pressure as far as reducing the number of OR visits. And it made me really scratch my head, because this was not consistent with other published work in this space, including my own studies where we studied PHMB versus standard negative pressure. Clearly, it seemed like the PHMB group did much better. And also, it wasn't just me. There were other studies, including Alan Gabriel's study using a different kind of antiseptic, and Mike Timmer's also using a different kind of antiseptic. So this was kind of out of sorts as far as compared to other studies. But I really started digging into the results of this study, and one of the things that I noticed was the length of treatment in the PHMB arm, if you will, the installation therapy with PHMB, was 9 to 21 days. In fact, the median was probably greater than 15 days of therapy using installation therapy. If you look at my study and Alan's study and Mike Timmer's study, what you'll notice is that the therapy days in all of those studies was much more shorter. And so that got me thinking, well, why is that? Well, as I alluded to earlier, I think the length of therapy, meaning the application of the antiseptic for a period of time, makes an impact as far as wound health conversion is concerned. Sure, within the first 24 hours, in any potent, really, antiseptic, including Dakin's, can kill bacteria. But then what happens to that wound bed? I think in many cases, these cytotoxic effects, these side effects, if you will, of these antiseptics become deleterious to the wound bed itself. And so I think that's why in this study, it did not meet the primary endpoint. I will tell you that, the algorithms have changed a lot as far as using installation therapy. And I'm just going to show you, I'm going to show you some recommendations that we came up with. I think that, use of hypochlorous acid, which is demonstrated, as Greg just talked about, really is really not cytotoxic at all. It does not hurt the tissue. So long-term or longer-term use is totally appropriate. And in this case, when you have ready access to the ORs, ready surgeons, willing to take the patient repeatedly back to the operating room, I think once you apply the installation therapy, the Bosch solution can be used as the irrigation solution throughout. One of my friends is an orthopedic surgeon out of Missouri, and what he talked to me about several years ago was the use of an antiseptic very early on. His preference was Dakin solution, but he said, you know what? I usually stop that within the first 24 hours. Then I switch to something like normal saline, and that's because of the cytotoxic effects of the tissue that he was observing. And as I think back about that conversation, he was absolutely right. If you look at the data, the benchtop data, it does tell that same story. But when you use something like hypochlorous acid or Bosch solution, you won't have that issue. And sometimes it's logistically easier to stick with the same solution throughout their hospitalization. Now, if you have limited access to the OR and perhaps just a single time in the OR surgical intervention, maybe it's just to decompress the infection, this is a really good time to use something like hypochlorous acid, because you may not have gotten to all that bacteria. You may have not been able to excise everything, and this may be very helpful. The other thing about using installation therapy with a solution like Bosch or hypochlorous acid is that if you have any concern that you did not get rid of the bacteria in the area, then it's sort of a fallback. It allows some some, not guarantee, that's too strong of a word, but at least some support that, hey, it's okay if I didn't do an exhaustive excisional debridement. Sometimes you lose so much tissue domain, you don't want to do that, especially in the lower extremity, and because you don't have a lot of soft tissue there. So this may be a good fallback to use an antiseptic solution like hypochlorous acid throughout their stay. I think the ideal situation, especially if you have limitations in OR access or limitations in the surgical team that's willing to take a patient to the OR, is using instillation therapy with hypochlorous acid prior to the first OR visit in preparation for perhaps final closure coverage. I think it's really important that we try to close or cover the wound while the patient's in the hospital. I know some people like to discharge that patient and then bring them back, but honestly, the patient's optimized where they're in an inpatient setting, and we want to try to get that wound converted as fast as possible to a point where we can close or cover. Now, in some facilities, there's no surgical team that's interested, or the OR access is terrible. So what do? This is especially a great time to use something like hypochlorous acid throughout their hospitalization with the combination of instillation therapy. So I know we talked about some broad topics here, and I wish we had more time to go into detail. And perhaps if you have some specific questions during the Q&A session, you should remember those, and you can sort of save those and we can discuss it. But honestly, I think that when you talk about solution choice, everybody focuses on it. And I think there is some energy that should be spent in thinking about that. The first thing that I think about is its efficacy or effectiveness of that solution, whatever solution that you decide to choose. And then the second thing is tolerability. Is there going to cause some adverse reaction locally? And then accessibility or availability. If you just simply can't get to a solution, then it's not pragmatic to try to go through the process of getting it into your facility. And then cost. Cost is a major driver now in healthcare. So we need to be cognizant of that. When you think about something like hypochlorous acid solution, you check all the boxes. Is it effective? Yes. Is it tolerable? Yes. Is it accessible? Yes. And the cost is significantly lower than any other antiseptic on the market. Thank you very much for your attention. We're going to hand it off to Marianne.
Well, thank you so much, Dr. Kim. You always have great commentary and bring clinical research into such a usable platform for wound care providers. My name is Marianne Opes, and I'm the complex abdomen specialist at Regents Hospital in St. Paul, Minnesota. And I'm going to talk today about clinical case results using hypochlorous acid, preservative solution, and instillation. Now, we all know that our wounds are getting more and more complicated every day, and patients are actually surviving these wounds. And so just like our patients, we have to keep, changing what we're doing and trying new things to really bring them to the next level. So I'm going to start today with one of these just adorable little 64-year-old ladies that just wanted to go home and hang out with her cats, but she ended up with this really bad infected leg, came into our hospital with all the normal comorbidities that you see with patients at this age, but really presented with flu-like symptoms and for sure was malnourished. She ended up in the operating room multiple times for us. And on the 21st of December, this is what she looked like. And I want you to really be a scientist at this point and look at this wound. Look at the peri-wound skin and see how you describe it in your head. And for me, it was odor-free and just really kind of dormant. It didn't seem to have any more necrotizing disease, but it also just didn't look healthy. But really take a good look at that peri-wound skin. It's such an important part of healing, is making sure the skin around the wound is healthy as well. And so one of the very first things that I talk about within, and if you ask any of the residents that work with me, I'm always like, how are we going to get this patient nutrition? Because we know wounds like this need like 1 to 2 grams of protein a day. And that's just the protein, they need calories and all sorts of stuff. But to try and actually ingest 200 grams of protein is just undoable. So we do a lot of hybrid, like put in a feeding tube and run the feedings at night and let them eat during the day, add some TPN if needed, those kinds of things. So discuss it early, discuss it often. So there's never a more proud moment than when your residents call and say, hey, can I put a patient in this instillation vac with our Bosch solution for wound healing? And I'm like, of course. And so she put the dressing on and decided on 50 milliliters of fluid and a 5-minute soak every 1 hour. And then on the 31st, one dressing change later, you can see the wound bed looks much better, much more healthy. There's granulation tissue, there's a better color to it. But look at the peri-wound skin, makes a huge difference. And I don't know if it's the healing of the wound bed or the contraction and release of the vac, but it definitely is healing the skin around the wound as well. So this is a couple days later, and you can see we're really making some progression. We usually take our patients to the shower to take down dressings, and she has wounds on both sides of her legs. It's kind of hard to tell from the pictures, but look at even over the foot, which I don't do a lot of footwork. You can see there's a lot of granulation tissue right up and over those exposed tendons. So tips and tricks. I really love these little barrier rings, and I put them between her toes, and then I clear draped over the top so that she could walk and she wouldn't loosen the vac. And then over here, you can see, I like to put the barrier rings 1/2 centimeter back from the junction of the granulation tissue and the skin edge so that I can clear drape up and over from the backside of the barrier ring into the wound edge. And that actually helps not only seal the vac, but it is a much more painless removal when it comes time. It protects that peri-wound skin from any maceration. And then the foam. So you have to make sure that this crazy waffle foam is actually against the wound bed. So you can see I'm tucking some in. I make slits into it anywhere I can just to make sure that it all lays nice, but right against that wound bed. And this is what we see at about, 3 or 4 dressing changes in. So be patient with this technology because it takes a couple of rounds to get to this healthy, skin graft type ready situation. And this is what she looked like a couple days after her skin graft. I think we grafted her mid-February. And hopefully back to her kittens. I think that's where she went. So what is this technology? It's a negative pressure or vacuum system that instills Bosch or a wound cleansing solution through the foam itself. It soaks at the interface of the foam and the wound and then deploys the vacuum again. So what does that look like? This is the foam dressing with the solution coming through. So you're like the wound itself. And you can see it's not like your kitchen sponge where the fluid stays in the sponge. It actually goes through the foam, interfaces at the wound bed where there's the debris that you just don't want in a wound bed. And then the negative pressure deploys, fractures that softened debris and puts it into the canister. These things, as technology gets trickier, you definitely want to make it easier for your staff. And so we made a VAC order for installation, which makes people actually answer all the questions that you need to have answered so that the nurses can check the VACs as they hit the floor. This is my favorite part of placing an installation VAC is that we have to decide on how much fluid. And if you have time and you don't mind, pop into the question and answer area. If you do this, how you and your team decides on how much fluid, because there's a mathematical equation, or you can use the fill assist button on the VAC, minus 20%, or like we just kind of eyeball it these days just because we've gotten kind of good at it. So it'll be interesting to see what you guys do with your installations. So I always like to show in lectures where our wonderful facility, maybe tripped up a little bit. And so we got this Bosch bottle with a squeeze top in initially. We love this product. We wash our wounds with it. We prep our patients with it. But then we wanted to put it onto the negative pressure system. So we were trying to figure out how to tape the bottom so we could hang it and that kind of thing. Well, of course, someone had already thought of it from the company, clearly, where they had bottle with a hanger on the back. The writing was upside down because you were hanging it. And we like to spike through their heavy cap. So we just wash it off with alcohol and spike through it. That way we don't have as much leaking at the cap base as it is hanging upside down. And this is what it looks like deployed on a negative pressure system. So this 27-year-old gentleman came from an outside state. Prior to arriving at our facility, he had had 7 debridements. We believe this whole necrotizing soft tissue injury started from a bug bite, but a lot of times we just don't know why. He had diabetes. He came in wet to dry dressings. had multiple OR trips at our facility before we put in the foam dressing. And I think that it's super important in necrotizing disease to not put on a negative pressure system too soon, because you need that frequent surveillance of the tissue to make sure that all the necrotizing disease is gone. But when it does become time, then it is important that we get these dressings on and that they stay on. And so this is another exercise where I would love it if you guys wouldn't mind taking some time, putting it into the question and answer section. How would you attack this? Like, I usually go easiest first, and I do all my bordering and everything and try and get like a big section that's more superior or towards the top of the wound first, and then I get into the more technical areas like the groin, and then the more dependent areas where the fluid drains. But if somebody has a really great methodology, I would love to discuss it at the end of this lecture. So this gentleman, he kind of had half of his abdomen and his leg exposed, and we really needed to get installation up and underneath that deep undermining. So I'll go through the foam and then under the undermining just to make sure the fluid gets in there, because it's just so important that that Bosch gets into the tissue to work with the waffle foam. And because each pump will only allow you one installation, we used 3 different pumps, and then we added extra negative pressure ports. And I usually try to think of it as the installation is the pitcher mound, and then the negative pressure ports are kind of like the bases in a baseball game. Secret sauce. I'm sure you all have your secret sauce. So if anyone has better secret sauce than this, please let me know. I like this wound wand. It really helps me to land vac drape on kind of those wet areas, and then these barrier rings. But we can go through a million barrier rings in these big wounds. So if someone has a really great idea, please let me know, or someone needs to actually develop something, which would be amazing. So this gentleman, we ended up with 9 vac dressings, and we only used 200 cc's of wound solution. And so I think it's funny because you'd think it would need a lot more, but you really don't need that much because that solution goes right through the foam onto the wound base. We did a 5-minute soak every 2 hours at a -150. And this is kind of goal accomplished for me. So I'm always trying to take the patient to the situation where some kind of final closure can happen. Skin grafting, maybe some small closures of skin edges, just to make these big wounds a little bit smaller and easier to deal with. So getting underneath that wound edge with the installation, I put the installation port between layers of the foam, and then I tuck it under like a taco. And this particular patient, we left the vac on for a very long time, several days, just because it was a really big wound, and we just kind of were giving this kid a break. So you can see that not only the tissue in the wound bed looks healthy, but the peri-wound skin looks amazing as well. I think it's an interesting point right here, and it'll be fun to hear what my fellow lecturers think about this. This is a section where they didn't have the waffle foam. I don't know if I just missed it or it got moved or whatever, but it's interesting to see the different in texture and quality of the tissue when the waffle foam isn't engaged. One question I get a lot is, can you use multiple vac pumps not in synchrony on the same wound, continuously? And the answer is yes. They are very smart pumps, and they have figured out how to not be in synchrony, but still all function. So his skin grafts were complete, and he got to go home on the 12th. But the reality is, this is a long journey for these kids, and skin grafts many times need some revisions and a lot of lotion and just a lot of care. Okay, let's talk a little bit different area. We had this gentleman come in for a robotic nephroureterectomy on the left and ended up with a bowel perforation. By the 31st, went in for an exploratory laparotomy, resection of the sigmoid colon, and temporary abdominal closure device. Unfortunately, by the 1st, we had to go back, take him for a washout, mobilize the splenic flexure, and give him a left end colostomy. On the 4th, we went back for a fascial dehiscence and reclosure. He had embolus in his IMA that had to be embolized. And then he also had a huge hematoma and drain placement by IR. Finally, his last procedure was a skin graft on May 7th. So what does this look like? On April 26th, they called me and said, can you come take a look at this fella and give us some, suggestions for a dressing? And so you can see here, he's got his end colostomy, but right here is exposed bowel. So he had a fascial dehiscence multiple times, and now he has exposed bowel. So this is not a patient that you want to use any kind of negative pressure system. And so what I do instead is do a very heavy zinc skin protectant around the edges. And then I just do Bosch Curlex on the wound bed, and then dry Curlex over the top, ABD and abdominal binder, and change it twice a day. And it's amazing the amount of work that this can do. So just a couple days later, you can see we really cleaned it up. He's obviously expanding his wound because he has no fascia intact. So it's just going to kind of get bigger in time. And you can see by May 5th, I called the burn service and said, you know what, I think he's, for sure graft ready by next week. And 2 days later, they actually brought him down and did a skin graft. This is what he looked like on May 10th. He did have little pockets of kind of just tissue underneath or slough underneath his graft. And we were a little bit worried about it, but we just continued with the Bosch wet to dry dressings. And by June 6th, he looked like this. He's now at home. This is a clinic visit. And these folks, we give reverse turtle shells because they're very insensate over that skin graft over bowel. And, he's out doing yard work. And so we don't want him to pick up something and pull it against his belly and not be able to feel, something hurting him. So we put him in this cute little reverse kind of teenage mutant ninja, turtle shells and tell them to, live their life for a year and come back in the year when we can reconstruct them and take his ostomy down and that kind of thing. I can't give a lecture without the word fistula because I love fistula patients. And this is a little gal that's a spina bifida patient of mine that I've been taking care of for a long time. And you can see here, she's got a urostomy with 2 stents and an ileostomy downstream that's non-functional. And then she's got 6 or 7 little fistulas here. This is her high output one. And I just can't tell you how important it is to have a good cleansing solution for these patients that have enteric contents all over. And you can see we use Bosch every single dressing change because we're putting her in these big wound managers, right, that cover all of this. So the stool is still on the skin in between, but as long as we can keep it clean and change, her dressings every couple of days, it's amazing that they will actually heal that skin up and do really quite well. And this is a little COVID gal that came in so sick. And when you lift it up, you can see here, I'm lifting her belly up, and underneath her belly, she had this tiny little fistula that was just draining caustic fluid onto her skin. And so, we didn't have a lot of options here. And so we just would have her, they would just wash her with Bosch every 2 hours, put a skin protectant and fluff gauze, and just great nursing care. And time made her, like this on the 26th, where we could actually put a pouching system on. So thank you so much for listening to our lectures. And I really look forward to talking to you guys and chatting with you in the question and answer section.
So thank you everyone for listening to those lectures. It's very informative. I certainly learned a lot from my colleagues, Marianne and Greg. We have several questions in the Q&A box, but I just want to start with just a kind of a commentary. It's interesting because if you think about antiseptics, it's ubiquitous. Everybody uses them, but there's very little discussion really around the use of antiseptics. There's so much more around grafts, about different kinds of dressings, different impregnated dressings, but really what we use on a daily basis for almost every patient is some sort of antiseptic. So it's a very timely discussion because we really don't give a lot of thought to it. And as I've talked to my colleagues across the country, they're like, oh, I like this, I like Dakin's, I like acetic acid, I like Bosch solution. Everybody has their preference, but nobody's really been very thoughtful in thinking it through. So with that, I want to start with Greg. I have a couple questions for you, then we go into the Q&A box and ask some questions that are in there. But you presented a lot of great science, great bench and animal studies. And I'm always kind of interested in those studies and thinking about extrapolating your understanding based on the data that was presented, that you presented. And what does it mean in the greater environment of a wound where there's so many more complex interactions with other cells in the area, just the human host factors that impact any drug, biologic, or device? Any comments on that?
Well, those are good points, Paul. And, we do laboratory studies to try to isolate the material we're testing to get a more controlled environment. And that's great because we can do relatively strong comparisons and say this works better than this or that or the other. The problem with the lab studies is we can never reproduce the incredibly complex matrix within a human wound. So it's good, but it's also bad. And one of the keys that is important, I think, for all of us to remember on this webinar is that what the laboratory data tells us is a most accurate factual information we can get under the conditions we do the tests in the lab. But what really is the key payoff is how does that translate into clinical experience? So the data that both you and Marianne presented on the use of disinfectant, antiseptic solutions, etc., those are the real take-home messages, because if the data from the lab isn't reproduced well in the clinic, then it obviously doesn't have the potential to impact patient care. So long story short is laboratory data gives us accurate, factual, comparative, analytical data, all those adjectives, but the reality is how does it translate effectively into patients? And the complexity of the wound environment, all the other proteins that are there, the cells, et cetera, blah, blah. We need to combine both of those to come up with the best consensus of how to use these techniques effectively.
Thank you. And as a follow-up to that, Greg, there was a question by Terry from Cedar Park Regional Medical Center, and I'm just going to read it to you. It is my understanding that the optimal strength of HOCl cleanser is 300 parts per million with no bleach present. Who makes this and where can we find this?
That's a great translation from all of the laboratory data into real clinical applications. And there is a product, the Bosch solution, that's an ergo product. Its concentration is 300 parts per million of hypochlorous acid, HOCl, because the pH of that solution is about 5.5. And you remember the pKa of hypochlorous acid is about 7.5. So 99.9% of all of the atoms are present as the protonated HOCl. That's in comparison to the common term bleach, which is the deprotonated acid, the sodium hypochlorite. And at Dakin solution of, say, around 10 to 11, there's essentially 0.001% of that would be present as the acid. Now, why does that make a difference? Two things. First of all, the cytotoxicity of the solution at pH 10 to 11 is substantially higher, orders of magnitude higher than the cytotoxicity of an equivalent concentration of HOCl, the hypochlorous acid, at similar concentrations. And also the second important point is that HOCl, the protonated acid form, hypochlorous acid, has twice the oxidation reduction potential as the deprotonated sodium hypochlorite bleach. Now, blah, 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 blah. What does that mean? It means it's more effective at killing the bacteria at lower concentrations of HOCl than sodium hypochlorite. So the bottom line is we want that very effective natural antimicrobial that our body makes inside the endocytic vesicles of the neutrophils. We want it to be HOCl, not NaOCl.
Thank you, Greg. We're going to move on, and I want to ask Marianne, there's several questions in the Q&A box, but I want to start with the case presentation that you showed using the hypochlorous acid over a skin graft. And I thought that was interesting because some people may be hesitant on applying anything over a skin graft, especially one that's not matured. Any comments on that?
Yeah, I mean, we definitely have moved towards that with our burn service that does most of our grafting, that they will do the gauze-based, Bosch over the top of skin grafts, having great results, really helping to, clean up any areas that, like the patient that I presented had these like little fluffy areas under the graft. And so we're definitely moving that direction more often. I don't know if you're doing that as well, but it seems to be something that's working nice for us.
Thank you. We have some limited time left, and there's a ton of questions, Marianne, that are some more practical questions that have been asked in the Q&A box, and perhaps if you have time, you can answer those directly to the people that are asking those. But there's one practical question. This is a good question. Does Bosch come in a spray bottle? Have you seen that, Marianne, or do you transfer it?
No, yeah, it's so funny. So that last little gal with the fistulas, her mom puts it in a spray bottle, and it works great. We don't always do that at work, but we definitely have. It definitely brings the product, like you can use a lot less of the product if you use it like that. And so I don't think it's sold that way, but I don't necessarily know that. But yeah, it's pretty easy to do, and we've had some good results with the patients, especially folks that are sensitive to touch. The spray bottle works really nicely.
There was another question here, Marianne, if you don't mind. Is the wound vac, this is from Georgette from Honor Health Thompson, is the wound vac with installation only used post-surgery?
Oh gosh, no. We definitely, just like kind of had talked about in your lecture, we'll use it to prepare people for surgery as well. And so it's a great way to keep the wounds clean and decrease bioburden, between sharp debridements, or if you can't get to sharp debridement. And sometimes it does the work for the surgeons. It definitely helps to delineate for our surgical service what areas need sharp debridement as compared to the areas that this therapy can actually clean up without sharp debridement. So definitely before, and at times, yes, after.
Yeah, and just as there were some questions regarding its availability. I know that you know this, Marianne, but for the audience, installation therapy is really only available on the acute side in some LTACs, so it's not an outpatient necessarily device. There's a question, I think it was more directly toward me, regarding is there any data, is there any clinical studies comparing head-to-head hypochlorous acid versus saline, and there's not, to my knowledge, any robust prospective study anyway. And I think that is a good study, and if I did publish a paper comparing PHMB versus normal saline, and looking back, I can see that I should have probably added this arm of using the hypochlorous acid as well, because the results of that study showed really no difference between normal saline versus PHMB, which may be, as I discussed in my lecture, the result of the deleterious effect of PHMB, because normal saline obviously has no antiseptic properties. Okay, we've run over a couple minutes, and I want to just thank all the attendees from listening to our lecture. I want to obviously thank Greg and Marianne and WoundCon and ErgoMed for their sponsorship of this event. Have a very nice and pleasant week. Thank you very much.
Thanks.
Yes, thank you.